Yeah, hi. Good evening. And I'd like to first thank the organizers for the opportunity to participate in this event. I'll be sharing on the topic of PAE. So I have no disclosures to make, except that I'm actually not an interventional radiologist. I'm a urologist. So there's no way I'm an expert in this procedure, but I'm an expert end user because I do send quite a number of patients to the radiologist for the procedure. This is my hospital where I work in, is Tan Tock Seng Hospital, 1,700 bed. So as you can see, it is actually co-located with the National Center for Infectious Disease. And I don't have to mention it, but you know what these people are doing. So a bit about the history of PAE. Well, the first reports of PAE being used was actually in the 1970s when it was used to stop bleeding in a case of prostate cancer. And several years later, it was used to stop bleeding in a post-prostatectomy patient. It wasn't until the year 2000 when PAE was reported for use in BPH patients. And since then, there have been many cohort studies as well as randomized controlled trials. So first of all, a bit of the procedure. It is done as a day case procedure under local anesthesia. And if the patient is on any anticoagulation or antiplatelet agents, they do not need to be stopped, especially if the indication for these medications are very imperative. However, in certain cases, if it's possible, it is of course safer to stop them. It has to be emphasized that it's actually technically challenging. And the interventional radiologist will actually cannulate the anterior division of the internal iliac artery, and then they will delineate the prostatic artery supply, and they'll catheterize that with a microcatheter, to which they will inject microspheres, right? They are ranging from 250 to 400 micrometers in size. This will then cause ischemic necrosis, liquefaction, and eventually shrinkage of the prostate gland. And there's also a reduction in the adrenergic receptor density, which helps to relax the smooth muscles in the prostate itself. These are some MR images done about 6 months after PAE. So you can see on the right side, those areas that are the white arrows are pointing to, they show the areas of liquefactive necrosis. And you can also notice that the overall size of the prostate has actually been reduced quite significantly. And even patients who have IPP, intraprostatic protrusion, may benefit from the procedure. So these MR images here show there is a reduction in the IPP. However, if you compare with the gold standard of TURP, obviously this is inferior to that. These are photos of specimens from animal studies. And you can see that in some cases, you can actually achieve quite significant infarction of big parts of the prostate gland. So in the last 5 years or so, there have been almost 20 cohort studies about PAE. And the problem is that the inclusion criteria, outcomes reporting, as well as the follow-up duration has been very heterogeneous. But nonetheless, they do show that there is improvement in IPSS, quality of life, peak flow, decrease in post-void residue volume, decrease in prostate volume. And interestingly, a few studies actually show there's an improvement in erectile function. There have also been several comparative studies done, including 3 randomized controlled trials comparing PAE with TURP, and also 1 comparing PAE with open prostatectomy. So following these cohort studies, interestingly, between the year 2014 to 2016, there were actually 8 systematic reviews that were published on the topic. However, they were of almost consistently poor quality, in terms of methodology and search comprehensiveness, such that there was a paper in European Urology in 2018 that criticized the quality of these systematic reviews. And fortunately, after that, there were several better quality systematic reviews that came out, and I'll share some data from this. So the first one is from a Swiss group, Zumstein and colleagues. So essentially what they did was to look at the outcomes of PAE compared to control, which is TURP or open prostatectomy. So even though it shows improvement in terms of IPSS, but they're inferior to control, right? So it is not as good as TURP. In terms of IPSS, quality of life, maximum flow rate, post-void residue, as well as the reduction in prostate volume, and PSA as well. And in terms of the procedure time, it actually takes longer than TURP, because it's actually a very technically challenging procedure. But what is in favor of PAE is actually a shorter hospitalization. And again, several studies show an improvement in the erectile function. So this table summarizes the findings that I mentioned above. There is another systematic review by a group from Denmark that compares, that basically summarizes the cohort studies, but it is not comparing to control, but just compared to baseline. Right, so it shows that, again, not surprisingly, improvement in IPSS, PSA, prostate volume, post-void residue, Qmax, quality of life. And in terms of IIEF, some studies show improvement, whereas some do not show. This shows the durability of the effects that are achieved. So you can see that for the parameters that are improved, it peaks at between 6 to 12 months. And beyond that, there is actually some deterioration in the improvement that is gained. But this is not inconsistent with the other minimally invasive treatments that that we consider nowadays. So what about adverse events? So again, the problem with many of the studies is the lack of consistency in reporting the adverse events. But if we were to look at just the Craven 3 complications, it is actually reasonably safe and is not inferior to TURP. In terms of major complications, the rate is less than 0.5%. And I think many of us here will be familiar with the two cases of bladder wall ischemia that has been cited very often as a complication of PAE. And of course, we all know that both cases required surgery to correct the complication. Okay, what about the major guidelines? How do they view PAE? So in the UK, as early as 2013, they actually looked at they considered PAE as a procedure. And at that point in time, there was inadequate evidence, and they concluded that more research was needed. But fast forward 5 years, in between, they have actually conducted a prospective cohort study within the UK multi-center trial involving over 300 patients, comparing with TURP, and they showed that it is actually efficacious and safe. And by 2018, the NHS has actually embraced PAE as one of the standard treatment and actually reimburses the procedure, even for public patients. For AUA, they are less friendly in terms of their position with respect to PAE. So it states that the level of evidence is not good enough and the quality of studies are low. It also has some concern about radiation exposure, post-embolization syndrome, the need for vascular access, the technical challenges, as well as quality control for low volume centers. And it concludes that PAE should only be performed in the context of a clinical trial. What about the EAU? So EAU, when I first looked at this last year, it classified the PAE as a technique under investigation. But 1 year later, it has actually updated its stand, and it acknowledges that PAE is less effective than TURP in terms of improving symptoms and in terms of urodynamic parameters such as the Qmax. It also acknowledges that the procedural time is longer compared to TURP. But as mentioned earlier, there are advantages such as lesser blood loss, as well as the hospitalization time in favor of PAE. And therefore, the recommendation from the EAU is that we may offer PAE to men who have moderate to severe LUTS, who are willing to consider a minimally invasive procedure and who are willing to accept a less optimal outcome compared to TURP. And it also emphasizes that we should only perform PAE in a center where the urologist is the gatekeeper. And they would actually select the appropriate patients and then collaborate with the radiologist to arrange for the procedure to be done and for subsequent follow-up. Okay, so there are, despite the limitations of the procedure, there are some specific clinical scenarios which I find to be very suitable for consideration for PAE, such as in the context of hematuria of prostatic origin. So because of the nature of the procedure, it is very well suited to stop prostatic bleeding. So in fact, if you look at the historical development of the procedure, the earlier reports were all for bleeding. And the good thing about it is that it can actually achieve control of bleeding quite rapidly, in most cases within 24 hours of the procedure. And for very large prostates, I would say in comparison with some of the other minimally invasive procedures, there is actually no maximum size that PAE has been shown to be limited by. And there are some reports of prostates up to 250, 300 cc that have been treated with PAE. And interestingly, there were actually several studies that compared the efficacy of PAE across different prostate sizes. And it shows that actually better outcomes are achieved with the bigger pre-treatment prostate size. And lastly, patients with indwelling catheters, many of them are very old and unfit for surgery. And they have no option. They are not fit for TURP. And what has been reported is that surprisingly high rates of successful catheter weaning after PAE, as high as 90%. But I think this is somehow different from my experience. So in my experience, I see about up to 50% of patients can be successfully weaned off. However, this can take several attempts at weaning, up to 3 months. So in conclusion, PAE shows good efficacy in treating BPH, although we would like to see better quality studies, especially randomized controlled trials. It has been shown to be reasonably safe with a low complication rate. And although there are disadvantages, which I mentioned earlier, such as post-embolization syndrome, radiation, and also not forgetting contrast toxicity during the angiographic procedure, it is something that we should keep an open mind about. And even though it's not been endorsed by some of the major organizations in their practice guidelines, I think that it is a useful option in certain clinical scenarios. And I just want to lastly acknowledge my favorite interventional radiologist, Dr. Sandeep, whom I think some of you may know. So he's the guy that I send all my PAE cases to. So that, I thank you.
Right, thank you, Iman. Before I go on to the questions, let me just welcome our viewers from Mexico, Turkey, and Morocco. Looks like more and more people are joining us. Yeah, so just as a mention to everybody, it's not just this Zoom webinar that people are tuning into, they're also tuning into a Facebook broadcast. Okay, so a few questions. First thing, of course, is this post-embolization syndrome thing. Have you seen it? Because it's classically described in post-embolization of the in the uterus. or uterine fibroids. Have you seen it in your patients who you've done for prostates?
So I've seen it in about maybe less than 1/4 of patients. They are quite mild. Some of them have a bit of fever and they just feel a bit lethargic. We would actually watch them at least overnight, even though earlier I mentioned that it can be done as a day procedure. But because we are still starting out, we keep them overnight, and most cases would resolve with Panadol. My radiologist actually prefers that we give them antibiotics for a few days, and I would oblige, even though if left to me, I wouldn't actually put them on any antibiotics. But so far, we've been giving them as a routine, at least as
How about
far as the radiologist.
Do you see a lot of dysuria that comes along post-procedure?
Not very much, not very much. So I mean, to be honest, my cohort of patients are all the very old and very unfit patients, and immediately after procedure, they are still on catheter, so they can't tell much of difference. And we would then try and wean them off at least after 2 weeks. As I said, some of them may require several attempts, up to several months before they are successful. And of course, there are cases that will still remain on the catheter.
Right. And I assume you stop anticoagulation for all patients, correct? How about antiplatelets?
We don't have to stop, but we will actually discuss with we look at the indication for the anticoagulation. I will talk to the cardiologist or neurologist. In some cases where they say that you can't stop, then actually my radiologist is actually okay to proceed. And in terms of the overall opinion of the community, is actually okay to perform it even while on anticoagulation.
So you mean warfarin on, or just convert to heparin?
So in the literature, actually, they say you can even do it. You can do it on anticoagulation. So it's safer to actually convert to heparin, but they can be on it. Yeah.
Okay. Any specific mention about median lobes?
No.
Just the size of the prostate, right?
Yeah, because some of these cases may not even have had an endoscopic procedure, so we do not know. But on the MR images, you could see that even with IPP, it actually shows some reduction. Right. But I guess cases that don't have a very high grade IPP would probably do better when it comes to weaning off catheter.
Right. There is a specific question here about bilateral PAE versus unilateral. Is there any mention when you discuss it that you do one side only or both?
So the different studies define technical success differently. So some of them define that you need to be successful in bilateral embolization to be deemed successful. That's the technical success. Some studies say that unilateral is okay, but when we look at the cases that only have a unilateral embolization performed, up to 50% of them would actually be achieve the outcomes, whether it's bleeding or in terms of catheter weaning. So right. Even if it's unilateral, in my opinion, it shouldn't be deemed as unsuccessful. Okay. Because there are some cases with very difficult vascular anatomy, and it can be dangerous if they try too hard.
Well, have you had any patient with chronic pain post, like chronic pelvic pain, like ischemic kind of pain? No.
No bladder ischemia as well.
Rectal ischemia? Is there any mention about in the literature of rectal?
No, I mean only the 2 cases of bladder.
The bladder. Okay, right. I think I've covered most of the questions that's come through. So thank you very much, Iman. It's been illuminating as usual.